When treating a complicated case like a calyceal diverticulum, I think knowing where your access is going to be and planning everything out with the anatomy is very important. I think having retrograde and antegrade access at the same time really allows you the opportunity to visualize exactly what's going on in the kidney and know exactly where you're putting your needles, your wires, your tubes, and it's the safest way to really get your access and keep your access and know where your access is. This is a case of a 58-year-old female with a 2.2 centimeter stone burden within a right upper pole calyceal diverticulum. She was bothered by pain. She also had some gross hematuria. No other history of nephrolithiasis. She had had a pretty significant urinary tract infection in the past. She did have a history of hypertension and diabetes, but no other real significant medical history. And so here's a picture of her non-contrast CT scan. And as you can see, here's the calyceal diverticulum. It was in the right upper pole, and there was a layering of a bunch of tiny stones here that were filling that calyceal diverticulum. This is the intravenous pyelogram that she came to us with, and what's very interesting, you can see both the large collection of stones in the diverticulum up here in the right upper pole, but in addition, you can see that she had a duplicated collecting system with 2 ureters here. We brought this patient to the operating room, and after she was intubated, we placed her in a prone split leg position. What's really helpful about that position is it allows us to have percutaneous access, but it also allows us to have retrograde ureteroscopic access at the same time. When we actually got access, there was a pretty purulent looking material that was expressed, and at that point, even though she had been on antibiotics, we felt it would be unsafe to continue. So I know there's some research out there that you may or may not be able to continue at that point, but we felt the conservative and safe thing to do would be to put in some tubes, get out of there, and give her some antibiotics and come back at a later date. So we put in a retrograde stent. We did not leave a string on that stent, and we placed an antegrade nephrostomy tube directly into the diverticulum and had that draining. We kept her overnight on some antibiotics just to make sure that she stayed stable. She had no fevers. We sent her home with a course of antibiotics and then brought her back in for the definitive procedure. At that point, we already had access into the diverticulum, but we put her back in the prone split leg position because we felt we would want to have through and through access and the ability to see what was going on. So we passed the ureteroscope up again once we had a sheath up in position. We were still watching that spot where the diverticulum seemed to connect to the urinary system. We passed a wire through the nephrostomy tube to gain access into the diverticulum, and we actually watched as that sensor wire popped into the collecting system. I don't think I would have felt as comfortable without the soft tip of the sensor wire kind of even attempting to probe around at all. So we saw this wire poking from the diverticulum into the system, and we were able to guide that wire down her ureter, into her bladder, and out through her urethra. So we had through and through access, out her back, all the way down and out her urethra. So at that point, we knew we were safe. We were able to use the balloon dilator to dilate up our access tract into the diverticulum. We used a Nephromax balloon dilator, which is our typical balloon dilator. We dilated up to 24 French. We were able to pass a sheath in at that point. The stones were small enough at this point that we basically passed a nephroscope, a rigid nephroscope, in through the sheath. We then passed our ultrasonic device through the nephroscope, and we were able to just suction all the small stones out very easily. The nice thing about having through and through access at that point was once we had cleared her of her stone, which we were sure of based on looking around with a flexible scope and also fluoroscopically, we were able to pass a stent from, in a retrograde fashion, up through the urethra, and we actually were able to coil the proximal coil up into the diverticulum. Now again, I think there's no research that keeping a stent through the opening that you've made into the diverticulum helps in the long term, that it allows that opening that you've produced into the rest of the urinary system to stay open any better. But I think we all feel that it's a good idea to try and continue that drainage out of the diverticulum to decrease her risk of forming new stones in that obstructed area. and she actually, we left her with no nephrostomy tube, just the stent as drainage. Postoperatively, she did well, and we use KUB with digital tomosynthesis to image our patients afterwards in addition to ultrasound. And you can see on both of these images that there were no residual stones up here in her right upper pole diverticulum. I think it's very important to pay attention to the anatomy of the whole urinary tract. But I think in patients who have a real complicated anatomy, like this patient with the duplicated system, it's important to keep that not even in the back of your mind, but in the front of your mind as you're attempting to get access. Because even something as simple as putting a needle into a big mess of stones in this patient's diverticulum, if you're in the wrong collecting system looking for where you're going, you're never going to find your way.